So shall we start the session?
Yes, ma'am, we can.
Okay. Sir. Good afternoon. Welcome to the fourth and final session of Pushpagiri Medical College webinar series being conducted as a part of the annual CME program from the Department of Community Medicine. Our theme is Resolution of Paradox, Solving the Conventional Concepts of Liability and Validity. This series of 4 sessions. 3 sessions were completed. First one was on Understanding the Lab Test in the wake of COVID-19 pandemic by Dr. Manasi Ravindranath. Second was on Liability versus Validity, often a trade-off by Dr. Devraj R. Third one was on Predictive Value versus Likelihood Ratio by Dr. B.G. George. For those who have missed, the session is available on Pushpagiri YouTube page. Kindly see it. Today's topic is on Choosing the Best Screening Test During a Pandemic by Dr. Anish T S, Associate Professor in the Department of Community Medicine, Government Medical College, Thiruvananthapuram. He did his MBBS, MD, and PG diploma in Public Health from the Government Medical College, Thiruvananthapuram, and PG diploma in Health Economics, Healthcare Financing, and Policy from the Health Foundation of India, New Delhi. He is currently a public health consultant with the Kerala State Disaster Management Authority and a member of the state expert panel of COVID-19. He is an epidemiologist with many publications in infectious disease epidemiology. He has more than 40 research publications with more than 600 citations. It is our privilege to have you for the session. I welcome Dr. Anish T S, sir. Please leave your comments and questions in the comment box. We will discuss it at the end of the session. Over to you, sir.
Thank you. Am I audible?
Yes, sir.
Thank you. At the outset, I would like to thank the organizers for giving me this opportunity. Not only for this opportunity, actually, they have shifted the timetable of the entire program because of my inconvenience. I am very thankful for that. And even the topic selection was also because of my intervention. So I would like to thank the organizers for that and welcome to all. Now we are going to discuss some other aspects of diagnostic test evaluation. Rather than a conventional diagnostic evaluation session, we are going to speak a little aspect about the community diagnosis. How a community is going to opt a diagnostic test, what are the intricacies in that, and what is the choice of a diagnostic test during a pandemic. These are the major things that I would like to discuss. So I can move to my presentation. Can you see my slides?
Yes, sir.
Okay. So our topic is choosing the best diagnostic technique during a pandemic. And we are using COVID-19 as a case study. Okay. When we are thinking about choosing a diagnostic test, the first one we have to keep it in our mind is what is going to be diagnosed. Because an individual may be choosing a test to diagnose something related to her disease status, but the community may choose a diagnostic test, which is something related to the spread of infection, maybe control, the effectiveness of control strategies and all other things. So first one is the diagnosis can be done at an individual level, as well as it could be done at community level also. That is the first point. Second one is, if this choice is taken at the individual level, one thing is usually we want to know the presence of the disease. We have to confirm the presence of the disease. Often we will be coming with a suspected diagnosis and we have to confirm whether it is disease or not. In case of COVID-19, antigen or RT-PCR is a is the test that we use to confirm the presence of a disease. Sometimes we may be having some symptoms so that we are going to suspect this particular disease. Or sometimes we may be having a contact with a person. That may be the reason that we are opting for this test. Anyway, the confirmation is one of the purpose of choosing a diagnostic test. Some other occasions, you have to choose a diagnostic test to ascertain the absence of a disease. Rather than confirming a disease, we have to, for example, if you are going to travel abroad or something like that, then you are doing the same test to know whether you are free from the disease. So in first one, if your intention is to search for the disease or to find the presence of the disease or confirm the disease, we will be going for a confirmatory diagnostic test. And if you are going to study or if you want to know the absence of the disease, usually we have to go for a screening test. In COVID-19, even these tests, that is antigen and RT-PCR, is used as a screening test also. You might have discussed what are the differences between a screening test and a confirmatory test in its attributes. Sometimes we may also discuss some aspect of that in the following session. And in some occasions, the individual may likely or may be urged to know the infectious nature of the disease. Sometimes you may be having the disease, but that may not be that much infectious, so that the people surround you or people is in your family, the family, other family members, or people in contact with you can be at safe. So we don't have much diagnostic options in that regard, but viral cultures are best option. And even in RT-PCR, we have got something like a CT value. CT value is cycle threshold value that will indicate how much virus is there or how much is the presence of antigen is there in your nasal or nasopharyngeal swab. So that is an indicator of the infectious nature of the disease. If your CT value is very low, that means you have got a heavy infection and you may be highly infectious. Suppose you have got a high viral titers, that is also indicating a chance of infectious nature of the disease. And often we have got some other diagnostic measures to check the severity of the disease, so that in a pandemic, the prioritization is a very important thing, because it is not like an individual going to have a test done, but it is the community is affected. So our resources should be prioritized. And if you are suffering from a severe kind of a disease, that means you have to given the resources. And suppose you have got only a mild kind of a disease, you can be kept at your home. So that is one aspect of that. For example, we are using this test like oxygen saturation by a pulse oximeter or a D-dimer analysis, or even we have got some other indicators of this TNF-alpha and cytokine storm indicators, and so many things are there. So these are the tests that we use in case of diagnosing something in an individual level. At the same time, we have to diagnose something at the community level. For example, if you want to diagnose COVID-19 in Kerala community, first we have to check the spread of infection. How much of our public is or people are affected by the disease? Usually, we have got the numbers of infections might be presented or reported in your website, but that may not be giving the true picture. If you want to diagnose the real spread of disease, you can go for a seropositivity analysis. Okay, how much of the people are harboring the antibodies against COVID-19? That is one thing. That is, again, we are going for a community diagnosis. Suppose the seroprevalence before vaccination is only 10% in Kerala, and if it is 50% in Bihar, we can very well conclude that in Kerala, the natural infection is much less compared to Bihar. Similarly, another one community level indicator or a diagnostic measure is the mortality measures like this case fatality rate and others. And even we can use surrogate measures like excess mortality. Even though your system is not able to pick up all COVID mortality, your system may be able to pick up the other deaths. And if there are increase in death in COVID period, definitely that is an indicator of COVID mortality. And we have got some force of infection measures. We want to diagnose the force of infection. We know that for the last 2 years, we are facing COVID-19 pandemic. But at this point of time, what is the force of infection? How much strong is this particular infection spreading in our community? In any pandemic, that is also important. To diagnose that, we have got many indicators like TPR, that is test positivity rate. We have devised some other indicator, WIPR, that is weekly infection population ratio or something like that. And even we are using some other diagnostic methods, may not be actually in a very small sample surveys and all. We are trying to diagnose the mutation also. Even now or today or yesterday, we were speaking a lot about the new mutation that is emerging from South Africa. And we are also trying to diagnose something from our community. So this same diagnostic test, okay, if you are using RT-PCR in an individual perspective, we are using a genetic analysis for the community perspective. If you are using an antigen test in an individual perspective, we are using the antibody test in a community perspective to study the seropositivity. So in a pandemic, we may be using a battery of investigations depending upon the sensitivity, specificity, and likelihood ratios. It has got different roles to play in a particular situation like that of a pandemic. So pandemic is actually giving you a particular situation where you have to opt many diagnostic tests for many diagnostic purposes. If you want to diagnose an infection, you may be using RT-PCR. But once you are diagnosed to have the infection, you may go for some other diagnostic test, that is maybe D-dimer, to assess what is the ability or what is the probability of blood clot to be there in your vessels. So many things should be carried out or maybe assimilated at the time of a pandemic. So choosing a diagnostic test during outbreaks is a very important thing, because in outbreak, the background risk goes on changing. Okay, in outbreak, for example, at the peak of outbreak, each and everybody you are meeting may be having an infection. But at the time of maybe at the tail of the outbreak, the chance of getting a positive result will be very low. It is not a constant. So we have to address, or we have to assess the diagnostics very carefully during an outbreak. For example, a person having viral fever is likely to have dengue at the time of dengue outbreak. But if the same person having something symptomatically indicating viral fever may not be dengue in the season, it is not. If it is not dengue season. So that is a very important thing. If a person is diagnosed to have IgM ELISA positivity for dengue in July, the chance of the real positivity is very high. But if the person is having IgM ELISA positivity for dengue, maybe in October, the chance of positivity may be low. That can be a false positive result. So the clinician has to just check the background chances of dengue or the background chances of COVID, whatever it may be. The background or the a priori possibility for the disease is very important to have a diagnostic clarity. Okay, just by getting a test positivity may not be, it can be a false positivity. A test negativity can be a false negativity also. So we have to assess the background chances of having a positive result or the negative result. Usually in individual perspective, we may be using sensitivity and specificity as the major diagnostic ability of the test. You might have heard that this snout and spin, sensitivity to rule out cases and specificity is rule in cases. For example, if you want to rule out cases, there is a chance of infection for everybody. People are coming to you. You are actually screening them for the infection. If there is a high likelihood, all the people should be screened. And if these people are not positive, or the negative people should not have the disease. That is the entire meaning of screening. Screening doesn't mean that the positives are having positivity, really positivity, but it means that the negatives are having really negative, because these people branded as negative are going to go back to the community and they may not come again. If these positives are there, they can be again tested to confirm the diseases. So that is the meaning of snout. Snout means if your intention is to rule out, you have to use a test which has got a high sensitivity. That means you will see that if a chance of positivity is there, it is not missed, so that it will be maybe categorized to a category of screened positives. Similarly, if you are in a situation where you want to rule in cases, that means you have to, if you are saying that this particular person is having disease, there should be definitely the disease. Okay, then you have to go for the test, which is high in specificity. That is the meaning of SPIN, that is specificity for ruling. If your intention is to rule in, then you have to use a test which has got high specificity. Sometimes it might have discussed already. This is a highly utilitarian principle that we used in diagnostic test evaluation, but it is not always true. That means if a test is having high sensitivity, that doesn't mean that the test is able to rule out. And if the test is having high specificity, that again doesn't mean that the test is highly effective in ruling cases. For example, what is the sensitivity of a test which gives positive result to all? ഒരു ടെസ്റ്റ് ആർക്ക് ചെയ്താലും പോസിറ്റീവ് ആയിരിക്കും എന്ന് വിചാരിക്കുക. പോസിറ്റീവ് റിസൾട്ട് മാത്രമേ ടെസ്റ്റ് തരൂ, അത് പോസിറ്റീവ് റിസൾട്ട് ഫിക്സ് ചെയ്തിരിക്കുകയാണ്. സപ്പോസ് you are going to perform 100 individuals where you do not know how many are positive and how many are negative. If these 100 individuals are undergoing this particular test, all of them will be positives. Okay, and we know that this test is a useless test. There is no use because this test do not have the discriminatory power to say positives and negatives are negative. ഈ ടെസ്റ്റ് ആകെ ചെയ്യുന്നത് എന്താണെന്ന് വെച്ചാൽ എല്ലാവരും പോസിറ്റീവ് എന്ന് പറയും. What is the sensitivity of this test? That sensitivity is 100%. Because why? So what is sensitivity? Sensitivity എന്ന് വെച്ച് കഴിഞ്ഞാൽ out of the real positives or actual positives or gold standard positive, how many of them were tested positive? ഈ 100 പേരിൽ ശരിക്കും പോസിറ്റീവ് ആയിട്ടുള്ള ആൾക്കാർ എത്ര പേരാണെങ്കിലും അവരെല്ലാം ടെസ്റ്റ് പോസിറ്റീവ് എന്ന് പറഞ്ഞല്ലോ. അപ്പൊ നിങ്ങൾ സെൻസിറ്റിവിറ്റിക്കകത്ത് അത് മാത്രം നോക്കിയാൽ മതി. ശരിക്കും പോസിറ്റീവ് ആയിട്ടുള്ള ആൾക്കാരെ ടെസ്റ്റ് പോസിറ്റീവ് എന്ന് പറയുന്നില്ലേ, മറ്റേ പാർട്ട് നമ്മൾ നോക്കേണ്ട കാര്യമില്ല. അപ്പൊ അതുകൊണ്ട് എ ടെസ്റ്റ് വിച്ച് ഈസ് ഗിവിംഗ് പോസിറ്റീവ് റിസൾട്ട് ഫോർ ഓൾ ഈസ് എ 100% സെൻസിറ്റീവ് ടെസ്റ്റ്, ബട്ട് ഇറ്റ് ഈസ് നോട്ട് സെർവിങ് എനി പർപ്പസ് because it is just, this test is just telling that everybody is positive. Similarly, if a test is telling everybody is negative, it is not at all analyzing the data or analyzing the sample. It is only just telling that everybody is negative. If you look the specificity alone, then that particular test has also 100% specific, but sensitivity is 0% and it cannot be used. So even though you can say that a test which has got highly sensitive is used for screening, and the test which has got high specificity is used for confirming, but definitely it is not completely true. You have to think about the sensitivity and specificity also. Whenever you are thinking the sensitivity, you have to think about or consider the specificity component also. If the specificity is something around 0, even if the sensitivity is 100%, that test cannot be used to rule out. Similarly, if specificity compartment is very important for a confirmatory test, but the sensitivity is also important. That means if you want to go for the real diagnostic ability of any diagnostic test, sensitivity or specificity alone will not serve the purpose. That is the role of likelihood ratios. I am sure that you might have discussed more about likelihood ratio in last class. So the positive likelihood ratio and negative likelihood ratio both are very, very important. Positive likelihood ratio is for ruling in, and negative likelihood ratio is for ruling out. In the place of sensitivity, you put the negative likelihood ratio, and in the place of specificity, you have to put the positive likelihood ratio. So you have to, whenever you are studying likelihood ratio, you have to think about what the likelihood ratio mean. For example, what is the meaning of positive likelihood ratio? What is the meaning of negative likelihood ratio? It is not the part of my subject, but even then I am trying to explain it more because it is very important. It may be the heart of the entire session or a webinar which is related to diagnostic test evaluation. Okay, what is the meaning of positive likelihood ratio? First one is the positive likelihood ratio is a concern if you have got a positive test result. Suppose I am a clinician sitting in my OPD and a person is coming with a positive test result. For example, he is tested positive for HIV. This person is coming to me, or this person is tested positive for COVID-19. This result is coming to me. Positive likelihood ratio has got a meaning in at the context of positive test result. Now I want to decide whether this is a positive or a true positivity, or it is a false positivity. Suppose the same. Similarly, if a person is coming to my OPD with a negative test result, okay, this person is tested negative for COVID-19, but symptomatologically he is very much positive because he has got fever, he has got lost his smell and taste, and he has got a contact with a COVID-19 patient last week. So many things are favoring a COVID-19 infection, but he is coming with a negative result. Then I have to just check whether it is a true negative or is it a false negative. So positive likelihood ratio is actually a contrast between true positive and false positive in the presence of a positive test result. Okay, it is the formula sensitivity divided by 1 minus specificity that you might have known. Okay, sensitivity means what is the out of true positives, how many are tested positive? That is sensitivity. Okay, denominator is 1 minus specificity. Okay, what is specificity? Out of tested negative, how many are out of disease negative, how many are tested negative? 1 minus specificity means, okay, out of negative, real negative in രണ്ട് റിസൾട്ട് വരാമല്ലോ. റിയൽ നെഗറ്റീവിന് പോസിറ്റീവായിട്ട് റിസൾട്ട് കിട്ടാം, നെഗറ്റീവിന് നെഗറ്റീവായിട്ടുള്ള റിസൾട്ട് കിട്ടാം. നെഗറ്റീവ് ആയിട്ടുള്ള ആൾക്കാർക്ക് നെഗറ്റീവ് എന്ന് തന്നെ റിസൾട്ട് കിട്ടുന്നത് ഇറ്റ് ഈസ് സ്പെസിഫിസിറ്റി. ദെൻ വാട്ട് ഇസ് ദ മീനിങ് ഓഫ് 1 മൈനസ് സ്പെസിഫിസിറ്റി ഇസ് ദ കോംപ്ലിമെന്റ്. നെഗറ്റീവ് ആയിട്ടുള്ളവർക്ക് പോസിറ്റീവ് എന്ന് റിസൾട്ട് കിട്ടും. രണ്ട് സ്ഥലവും ന്യൂമറേറ്റർ പോസിറ്റീവ് ആണ്. ഒരിടത്ത് പോസിറ്റീവ് ആയിട്ടുള്ളവരിൽ പോസിറ്റീവ് എന്ന് കിട്ടുന്നു, രണ്ടാമത്തെ നെഗറ്റീവ് ആയിട്ടുള്ളവരിൽ പോസിറ്റീവ് എന്ന് കിട്ടുന്നു. അതായത് ഈ പോസിറ്റീവ് റിസൾട്ട് പോസിറ്റീവിൽ പോസിറ്റീവ് എന്ന് കിട്ടുന്നതിന്റെ എത്ര ചാൻസ് കൂടുതലാണ്, പോസിറ്റീവിൽ പോസിറ്റീവ് എന്ന് കിട്ടാൻ എത്ര ചാൻസ് കൂടുതലാണ്. പോസിറ്റീവിൽ പോസിറ്റീവ്, റിയൽ പോസിറ്റീവിൽ പോസിറ്റീവ് ടെസ്റ്റ് എന്ന് വെച്ചാൽ ദാറ്റ് ഈസ് ദ മീനിങ് ഈസ് ഇറ്റ് ഈസ് ട്രൂ പോസിറ്റീവ്. ആൻഡ് നെഗറ്റീവ്, ആക്ച്വൽ നെഗറ്റീവിന്റെ പോസിറ്റീവ് റിസൾട്ട് കിട്ടുന്നു എന്ന് വെച്ച് കഴിഞ്ഞാൽ ഇറ്റ് ഈസ് ഫോൾസ് പോസിറ്റീവ്. ഇറ്റ് ഈസ് എ റേഷ്യോ ബിറ്റ്വീൻ ട്രൂ പോസിറ്റീവ് ആൻഡ് ഫോൾസ് പോസിറ്റീവ്. സിമിലർലി വി ക്യാൻ അനലൈസ് ദ negative likelihood ratio also. So now you have to think more about likelihood ratios. Likelihood ratios may be the most important diagnostic criteria that we can use to assess any diagnostic test. That is, അതായത് നമ്മൾ യൂഷ്വലി സ്ക്രീനിങ്ങിന് വേണ്ടി സെൻസിറ്റിവിറ്റി, കൺഫർമേഷന് വേണ്ടിയിട്ട് സ്പെസിഫിസിറ്റി, ദാറ്റ് algorithm you have to change. For screening you can go for the negative likelihood ratio of the test, and for confirmation you can go for the positive likelihood ratio of the test. And another thing that you have to keep it in your mind is you cannot depend on the positive predictive values, because predictive values will change with prevalence. That might have also discussed in your previous lectures. If you are giving the same test, which has got the same sensitivity and specificity in two locations, where you can see the two tables here. First table is the same test, which has got 90% sensitivity and 90% specificity is given in a context where 50% out of the 1,500 individuals are positive. The same test is done in a second context where out of 1,000 only 100 is positive. You can just check what is happening, the positive predictive value. In first instances, out of 500 people tested positive, 450 is actually positive. That means it is 90%. In the second aspect, only 180 is tested positive. Out of this 180, only 90 is actually positive. That means the positive predictive value is only 50%. The same context, same test, but because of the changes in the background prevalences, the positive predictive value will change. So this is also very important. Okay, people, especially the people or diagnostic people coming from the diagnostic side, or people coming from the companies, may fool you by just telling you the performance in predictive values. So predictive values are not dependable at all. We can very much alter the predictive value, even if the sensitivity, specificity, positive likelihood ratio and negative likelihood ratio of the test is very, very bad. That is one thing. And it is again important in the context of a pandemic or an outbreak, because at the peak of outbreak, the chance of everybody is having actually positive will be high. At this point of time, even as a bad test will perform good in terms of predictive values. But if this particular pandemic is getting over, or it is waning off, or is it between different, it's actually between two curves, the predictive values are not going to be performed well. അതായത് കോവിഡ് വളരെ പീക്കായിരുന്ന ജൂൺ മാസത്തിൽ ശരിക്കും ഇപ്പം RT-PCR. Hello?
Sir, in the comment box, actually, some participants are asking to how to speak in the regional language. Can you?
Okay. Thank you. Okay.
Thanks.
Okay. My point is, if you are going to diagnose, suppose I have got RT-PCR positivity during May or June, during the COVID-19 pandemic, peak of COVID-19 pandemic, each and everybody has got a chance of getting COVID-19. That means the pre-test probability of COVID-19 is very high. Your predictive value might be very high for the same RT-PCR, which may not be having that much high predictive accuracy at the time where in December there is very small or the epidemic is coming down. So out of 100 people tested for RT-PCR in May, 90 may be really positive, but out of the 100 people tested now, maybe only 50 maybe or 60 may be really positive. So that is another implication of predictive values at the time of outbreaks, because at the peak of outbreaks, you can depend more on the test result, but at the time of the tail of outbreak or between two outbreaks, the predictive values are going to come down. That is another aspect or another application of what you have studied already. Okay, this is our original slide. To diagnose at individual level, for confirmation and for screening, we are using RT-PCR or antigen. Okay. Again, we have already discussed. To confirm the diagnosis, be sure about a positive diagnosis, or you can be sure about a negative diagnosis. If your purpose is to confirm a diagnosis, you can be very sure about a positive diagnosis. For that, you have to use positive likelihood ratio. The test which has got high or the maximum positive likelihood ratio will give you the confirmatory diagnosis. And if you are interested in a negative diagnosis, that means if you are interested in screening, a test which has got very low negative likelihood ratio. Negative likelihood ratio should be very low for screening test. That is one point that you have to keep it in your mind. And if you compare antigen and RT-PCR, there is a lot of conflict between antigen and RT-PCR as a diagnostic test in COVID-19. Because definitely RT-PCR is technically better than antigen. So the sensitivity of RT-PCR is higher than antigen. Even the specificity of RT-PCR is also higher than that of antigen. If you look at the positive likelihood ratio or the negative likelihood ratio, the RT-PCR may be better test compared to antigen. But there is so many other things, because these things are also very important at the time of a pandemic. Because at the time of a pandemic, you cannot depend only on the technical efficiency of the test. Because a pandemic is affecting the community, and there is a lot of other forces will be there in the community. For example, one such force is in case of RT-PCR, we have got a false positivity due to RNA littering effect. That means you are diagnosing COVID-19 not to see that this person is harboring a particular genetic material responsible for COVID-19. You are trying to diagnose COVID-19 to see that this person is suffering from an infection. But RT-PCR is not actually diagnosing infection, but RT-PCR is diagnosing the presence of a particular genetic material. But that genetic material can be there in the nose and throat of the person even after the infection. That is one possibility that will bring maybe false positivity result in case of RT-PCR. That is one challenge that we are going to face while doing RT-PCR. So Government of India and Kerala government also have come out with so many things to avoid this false positivity. One is to avoid the exit testing. Okay, because if you have got a COVID-19 infection, you have to treat the infection and you have to keep yourself at your home to prevent the infection to others. At the end of 10th day, you may be free from infection. Okay, that means we have got maybe that study I am going to show in the next slide. And we have got enough evidence that the virus is not going to harbor in your body in its live form, maybe may not be more than 10 days. So it is, you can be free and you can go out to the community after 10 days. But if you are going to test again, your RT-PCR may be positive because of the RNA littering effect. Or that is a very important thing that will bring a lot of false positivity to RT-PCR. And there can be false negativity due to technical issues. For example, sometimes there will be viruses in your nasopharynx, and sometimes the probe may not reach till your nasopharynx, and sometimes it may not collect enough sample from your nasopharynx, and all those things can be there, and it will bring something like a false negativity also. In a textbook or in a classroom, you can study or compare the differences between RT-PCR and antigen, but these kinds of things are there. The practical reasons are there in the community. And it's a lot of externalities are also there at the time of pandemic. Rather than you just look at the sensitivity and specificity, cost is a very important thing. If you want to do a RT-PCR, sometimes the unit cost will be somewhere around 1,000 rupees. But sometimes the antigen could be done in 200 rupees. The cost of one RT-PCR, you can do 5 antigen. And the 5 antigen together may be giving you more yield at the time of an outbreak or at the peak of outbreak compared to one RT-PCR that is done at the same cost of these 5 antigen. So you can maybe escalate the number of tests at the time of peak by just looking at the cost. Sometimes you may opt a test which is technically less efficient to maybe to increase the numbers at the time of peak. But in between outbreaks, or if the number is going to come down, definitely you have to go for RT-PCR, because RT-PCR is technically a better test compared to antigen. There is another thing is because of the technical difficulties, because RT-PCR you need a lab. You cannot do RT-PCR in maybe in a remote rural area where we do not have a lab. If you want to do RT-PCR, you have to collect samples and you have to transport it to maybe a regional lab, and you have to get the result, and the result should be go back again to the rural area, and you have to communicate people that 5 days before we have took some samples from here and now it is trying to be positive. But during that 5 days, sometimes the infection might have happened. So you have to give the result at once, even if you are using a technically lesser or test in the place of RT-PCR. Sometimes you may be using antigen, but this antigen has got these kinds of advantages. So if you look at the antigen RT-PCR clash or conflict, at the time of large outbreaks, definitely there is a choice towards antigen. Maybe it is wise to choose antigen because of the reasons that may not be completely on the diagnostic efficacy of the test rather than the externalities. So these are very important aspects. And again, if you go for the other options, like if you want to know the infectious nature of the disease, it is very important to know the viral cultures, because now we know that the virus is not going to be there in live form after 10 days because of the cultural exercises that we have done. And it is again published in Nature that the virus in human body, the COVID-19 or SARS coronavirus 2, will not be staying in human body more than 10 days. Okay, it is actually rapidly coming down, the viable viruses. Maybe you may be knowing that the shedding of virus or live virus will be maximum at the time of pre-symptomatic period. Suppose if tomorrow you are going to develop cough and fever, today is the maximum number of people will be infected from you. And it may continue maybe a few days from the start of symptoms also, but it will be rapidly coming down. After a week or so, there is very low chance that you can give the infection to others. But the problem is you can start the giving infection early, even before you may be developing symptoms, or that is the worst part of that. But definitely, these are very important. If you want to diagnose the chance of spreading, rather than your presence of the disease, if you want to diagnose the chance of spreading, you have to go for some other diagnostic methodologies like viral assessment or viral cultures. Or one surrogate measurement that we can use is the CT value in RT-PCR. The CT value means it is cyclical threshold. That means how much cycle of PCR was done to detect the virus. If the cycle threshold value is low, that means high viral load. And if the cyclical threshold is high, that means low viral load. If it is somewhere more than 28 or 30, you need not bother, that there is less chance that you may infect others. But if it is less than 30, or if it is sometimes it may be less than 20, even less than 10, that means you have got a high viral load and you can infect others. And in COVID-19, again, so many other diagnostics are there, because in a pandemic, it is definitely diagnosing diseases or diagnosing infection is important, but maybe more important is to diagnosing the severity. Because if you look at pandemic of COVID-19, it is rather a pandemic of a flu or a pandemic of a viral fever. Okay, you need not bother if there is a pandemic of viral fever unless there are death tolls, or people are dying, or people are becoming severely ill, then we don't consider this as a pandemic at all. We have got the pandemic of common flu. In every season, a significant proportion of our people are suffering from common flu, but we are not bothered. Why? Because it is not creating deaths and miseries and maybe severe kind of illness. So severe kind of illness, diagnosing the severity of illness is very important aspect. In pandemic, we have got a lot of tests. Again, we have got maybe a challenge or maybe a conflict between the diagnostic efficacy and feasibility. For example, oxygen saturation. What is your pulse oximeter may not work at all. Your pulse oximeter may not give you the real oxygen saturation of your arteries. But definitely pulse oximeter is the only device that we can use in the field. It is less costly. So if you can just puncture your femoral artery and you can send blood for oxygen analysis, definitely that may be technically better result compared to a reading in the pulse oximeter. But pulse oximetry is a better technique because of the feasibility issues. So these things, the conflict between feasibility and diagnostic accuracy is again important in case of diagnosing severity also. And again, we have to diagnose again D-dimer, measures of cytokine storms and all other things that we have discussed already. And now another very important concept or component of diagnosing things during a pandemic is we have to diagnose something in the community. For example, if you want to diagnose the spread of infection, then you have to check the seropositivity. Okay, if you are just going to a lab and you just check what is the antibody level, it may be important for you because it may be indicating the effectiveness or the presence of some kind of an immunity in your body. And you can be pretty confident that even if you are going to get an infection, it may not be severe because you have got high titers of antibody. That is the importance of getting an antibody done in an individual perspective. But for a community, if the presence of people or the proportion of people having high titers of antibody is very high, that is indicating that this particular community is immune, maybe because of natural infection or because of vaccination. So that is a very important aspect of the community diagnosis, and we can be very much confident. That is, even now, Kerala, we people are so confident, even if we have got maybe large number of infections, even a single day, we have got 5,000 to 6,000 infection, which is somewhere around 50 to 60% of the total number of infection reported all over India. We are pretty confident because we know that our seropositivity is very high and the chance of severity and death is very low, even if there is COVID-19 spread in the community. For the time being, that we do not know what is going to happen if the new variant is going to arise or not. Another is the mortality. So this is seropositivity, and you can see that this is in the comparison between the seropositivity before vaccination era. The seropositivity of India is how it is growing, and seropositivity of Kerala, how it is growing. It is giving you a diagnosis of the community that the spread of infection is much lower in Kerala compared to other part of India. So another thing that we use in community is to diagnose mortality. Definitely we can go for CFR, that is a case fatality ratio. How out of 100 people infected, how many are going to die? That is one of the measurement. But the problem is sometimes we may not be having data to diagnose this. So we have to use some other things to diagnose. Surrogate measures of excess mortality. If you can, this is a publication that is in Nature, that in India, there is a lot of COVID-19 deaths, but definitely we are not aware of that. So these kinds of things can also be used to diagnose the community level mortality and all. Okay. And on a day-to-day basis, maybe the most important aspect of diagnosing something in the community is the force of infection. So in a pandemic period, the infection may be spreading all over the community and people may be testing. But we have to know, is it going high is having a maybe a higher trend, or it is coming down or something like that. That is known as the force of infection. How much, just like checking, suppose there is wind and you are just checking how much the force the wind has. Is it going to take away our roofs or something like that? So we have got some other measures in COVID-19 pandemic. That is, one is TPR, that is test positivity ratio. And second one is actually another indicator, that is WIPR, weekly infection population ratio. Because TPR is actually a very good indicator, but it has got some drawbacks. Because what is meant by TPR? TPR is test positivity rate. Out of 100 people tested, how many are going to be positive? Okay. The problem is, if there is a random sample, randomly taken 1,000 individuals in city A and randomly taken 1,000 individuals in city B, or in city A, out of the 1,000, 100 tested positive, 100 divided by 1,000, that is 10%. TPR is 10%. But in city B, only 50 were tested positive. Out of 1,050 tested positive, 5%. TPR is 5. Then we may conclude that in city A, the force of infection is high. That means the infection is moving at a faster rate compared to city B, because in every 1,000, we are seeing 100 positive cases. But the problem is, sometimes the situation may not be true because we are not doing it in a random sample. Suppose there is the situation or the system in city A is good, and they have got a very good system to send the people who has got high likelihood of positivity. The doctors are good, the field workers are good, they know where the infection is happening, and they are trying to find out people. And these 1,000 individuals are actually having a higher chance of getting a positive result. They are going for testing because they know that they have got a high chance of positivity. But in city B, these kinds of exercise is not at all taking place. 1,000 individual just mean that randomly taken 1,000 individual, they may not be contacts of COVID-19. The sample may not be taken from place where COVID-19 outbreak is taking place at all. In that context also, you can get the same result. Where the activities are good in city A, you may get high TPR. If the activities are very low in or bad in city B, you may get a low TPR. That means TPR may not sometimes mean the force of infection. Increasing TPR may be a sign of increasing activity or the higher vigilance of this particular area towards the particular disease. So in COVID-19 or any other pandemic, screening out cases or finding out infection is very important. If a particular location is successful in that, definitely the TPR will be high. So we cannot brand them as maybe failures or something like that. So that is an issue. So in Kerala, we were using some other indicator, that is WIPR, where we are not considering the number of tests. We are only considering the population, because tests can be altered. Okay. Suppose there are 50 individuals positive out of 100 tests. Okay. Your TPR will be 50%. If 100 tested positive out of 1,000 tests, your TPR is only 10%. But at the end of the day, in the first area, you have got 50 cases where the TPR is 50. And
Not audible, sir. Sir, are you there? Sir, it's not audible. I think there is some technical issue with the speaker, so we are trying to resolve it.
Am I audible now?
Yes, sir.
Okay, sorry. Okay, can you see my slides?
Yes, sir.
Where it was?
Yes, sir.
Okay. Till which slide you were able to see? We finished this one?
16, sir. 16. Slide number 16, sir.
Okay, this one.
Yes, sir. 16.
Okay, okay. We were trying to discuss the conflict between TPR and WIPR. Okay, TPR is test positivity rate. Did you hear what I said about TPR? Do you want me to repeat the implication of TPR and all?
Sir.
Hello?
Till TPR and WIPR.
Okay, okay. So I was actually trying to discuss the last portion of my slide. That is the diagnosis things in a community perspective, especially at the time of pandemic. It is not the individualistic perspective in a hospital. Suppose I am just sitting in a hospital, a person is coming to me with COVID-19, or a person is coming to me with a particular disease, and this person has got a very peculiar characteristic. Okay, for example, this person is suffering from HIV/AIDS, is coming to me, and I am trying to give some kind of drugs or antiviral drugs, and this person is not responding to the drug at all. And these kinds of occasions, even you can send a sample for genetic sequencing so that you can see if there is a variation in the genetic nature of this particular virus, that the virus is not responding to the treatment. The same thing you can apply in case of tuberculosis, and you may be able to find out new variant of tuberculosis which is resistant to treatment or something like that. This can be done in a individualistic point of view in a hospital setting if you have got collaborations with a very good laboratory. But this is further more important in case of a pandemic. In a pandemic situation, these things are very important because you know that COVID-19 pandemic in India was worsened because of a variant of concern, which is known as Delta. The Delta strain was identified by the scientist, maybe late 2020 itself, and it has got large mutations in its receptor binding domain. RBD is the receptor binding domain. Or mutation in receptor binding domains are very important for a strain, because receptor binding domain means the spike protein. Spike protein is used by this particular virus to infect human beings. If there is a structural change in the spike protein, it may be having high efficiency to attach with the ACE2 receptor that is there in human cells, and it can go into human cells much effectively compared to its maybe parent virus. So that is a very important aspect of controlling a pandemic, because these kinds of genetic analysis of genetic variations, genome sequencing studies are also very important diagnostic tests that we can use in pandemics. So this is what I have found today in internet. This is the key mutation in Omicron. Omicron, most of you may be knowing, or you might have heard for the last couple of days, that this is a new genetic variant. Now WHO is declaring it as a new variant of concern, and it has got many mutations in the receptor binding domain of this particular virus. And there is a chance that a future outbreak is because of Omicron. So that is the thing that again important in COVID-19 pandemic, not only in COVID-19 pandemic, for any other pandemic. That means the pandemic or outbreak situation is putting you in a particular position where you have to use a lot of diagnostic tests. It is not only a single diagnostic test. For different purpose, you have to use different diagnostic tests. That is one aspect of that. Second one is, rather than the technical efficiency of sensitivity, specificity, positive likelihood ratio, and negative likelihood ratio, you have to consider many externalities like cost. You have to consider the facilities for you to test it out. You have to consider the people's acceptance for getting it test done. You have to consider, and so many things that you have to consider. So again, you have to devise some diagnostic criteria for the community as well, also to see the spread of infection and how much of your people are affected, how much of your people are again prone for infection, how much of your people are having some kind of unique viruses harboring in them, how much of your people are prone to get infected again from the other people who can be infectious, or so many things that you have to consider. And maybe if you just look at the COVID-19 pandemic, you can see that the diagnostics or the evaluation of diagnostics was contributing much to the fight against COVID-19. So that is, COVID-19 is a wonderful occasion or a context where again you can study the various aspects of a diagnostic test evaluation. So that is the end of my session, and thank you. Sorry that in between I lost some connection or I lost the sound. Thank you.
Does anyone have any questions? So we got a comment from the comment box asking about WIPR.
Okay. Actually, WIPR, the meaning of WIPR is weekly infection population ratio. So we were trying to overcome some issues related to TPR. TPR is test positivity rate. It is actually, this WIPR was introduced in Kerala to overcome very selective issues that we were facing in Kerala. It is not applicable to maybe some other countries or something like that. In Kerala, once according to the Government of India instruction, we were using TPR as a very important yardstick. For example, if an area which has got TPR is more than 15, that area has to go for lockdown. And if this area is having a TPR more than 10, there will be strict containment. May not be lockdown, but there is strict containment in that particular locations. If the TPR is less than 10, that area could be kept free. So there was an urge to keep the whole area of Kerala free by keeping it less than 10. Okay, if a panchayat is seeing that there is so many cases in that particular panchayat, if the TPR is 15, what the panchayat was doing, they will just pump in a lot of tests in that particular locality. In a particular area, 500 tests were done, and out of the 500, 100 were tested positive. Then 100 divided by 500, you will get 20%. TPR is 20. So that panchayat should go for lockdown. So they will be in lockdown for 1 week. But after 1 week, what was going to happen that this panchayat will try to grab maximum test as possible. Instead of 500 tests that was done in the previous week, this panchayat will do maybe 2000 tests. Out of the 500, 100 positive and TPR was 20%. But suppose there is no control, real control has happened in that panchayat. The case number increased from 100 to 200, but they are testing or conducting 200 tests. So because of that 200 or the inflation in denominator, 200 out of 2000, you will get only 10% and the panchayat will escape. So TPR is a highly manipulatable indicator. So that by just increasing the denominator, you can just increase or decreasing the TPR. The problem with this strategy is that if this particular panchayat need to have 200 test kits, it may be mobilized from the adjacent panchayats. For the adjacent panchayats, do not having enough test kits. Instead of maybe 500 in the next round, they might have done only 100 tests. If out of the 100 tests, 25 turns to be positive, because definitely if there is only 100 tests is available in a panchayat, it may be earmarked for people who are more prone for infection. So there is high likelihood of testing positivity. That means if A was locked down in this week, B might have locked down in the next week. The third week, the C might be going for the lockdown. So there is no enough control is taking place. The people were playing with TPR. The intention was to just to reduce TPR less than 10. So one of the major aspects of this issue is TPR is a highly manipulatable indicator because of the denominator is number of tests, and the number of tests can be increased or decreased upon the decision of the panchayat or the people concerned. So government of Kerala was trying to just tide over this problem by keeping the denominator fixed. So how can we keep the denominator fixed? We will take the entire population of this particular locality. And if the number of infection captured is more than a particular mark, then the restrictions will be there. If the number of infection is less than a particular mark, the restriction will be diluted. So this has also some issues. For example, if the infections were less captured, as the denominator is a constant, then WIPR is going to be reduced. So sometimes the test may not be performed in particular panchayat to reduce the WIPR. It can happen, but people were, or in districts, the collectors and all, were in a consensus that they can see that every panchayat are doing at least a minimum test. And this test were something around 500 tests for Grama Panchayats and somewhere around 900 tests for municipalities and 1,250 tests for urban wards in corporations, something like that. It is fixed so that it will ensure that the enough number of tests will be there. But it won't be allowing more number of tests because the panchayat may not be getting an upper hand by increasing the number of tests. So that is actually a strategy that is played by government of Kerala to reduce the foul play using TPR. But I don't know how much it was effective. But that was the context that WIPR was introduced.
So 2 more questions also came in the comment box. Considering the vaccination status in India, should we worry about Omicron now?
Vaccination, two things are there. Rather than vaccination, if you just look at the India or pan-Indian situation, there is a natural infection might have happened everywhere because of Delta. So vaccination will not completely prevent Delta infection, but a real Delta once happened might be preventing new Delta infection. So that may be the reason that India do not have any infection now. So infection rate in India is much, much less, not because of the rampant vaccination, but because of the Delta, real Delta infection that might have happened in every part of India, including that of Kerala. Maybe in Kerala, the vaccination component is slightly more because the complete vaccination in Kerala is somewhere around 65%, and one dose vaccination is somewhere around 95% of the adult population. But in India, it is somewhere around 30% and 65% respectively. So if you look at the component of the protection in pan-Indian situation, the major component is the real infection that has happened and the vaccination also. But in Kerala, again, it is a hybrid, but the vaccination component is more compared to the Indian state, and the natural infection component will be less. Even if it is in India or in Kerala, this situation is able to prevent a Delta infection, which is the most successful type of genetic variation ever found. That is the reason that there is no much COVID-19 cases in India. But the real challenge is Omicron, because Omicron is maybe having some other immune escape kind of nature that we do not know now, because people are conducting a lot of studies in Omicron. And suppose the Omicron has got a real immune escape nature in presence of Delta, it can swoop again in areas where once infected by Delta. That is the real challenge that we are facing, because we are preventing Delta because of the prior Delta infection that was happening in India in May and June. So now if there is a swoop by Omicron can have fresh infection again in India, and again we can go for a wave that can be a third wave for India. So we are at a threat of a third wave, but that we do not know much, because we do not know how much immune escape nature is there for Omicron against Delta. That is a real question, or maybe $1,000 question that we have now. But even if Omicron is going to sweep in India, definitely the mortality rates may not be as high as that was because of Delta, because the infection as well as the vaccination is going to protect you. So you will be getting some kind of a partial immunity against any genetic variation, and it is going to protect you from death and severity. Fortunately, partial infection in COVID is protective. Okay, it's not completely protective against an infection. At least it is going to protect you from severe kind of disease and death. But in some diseases like dengue, partial immunity of one genetic variation is detrimental for the infection with another genetic variation, because of the this antibody-mediated immune enhancement and all. That kind of a phenomenon is not reported in COVID-19 rampantly. That is something fortunate, that a new genetic variation may not be having a detrimental effect. But definitely there is a chance of another outbreak because of Omicron. We have to watch very keenly what is the peculiarities or attributes of Omicron. At this point of time, we can only speculate. We do not know, or we do not have much data on that.
One more question from the comment box. Role of anti-spike antibody values against COVID-19 in predicting protection after vaccination.
Okay. Usually we are measuring the anti-spike antibody. Anti-spike, you may be knowing that the antigen antibody interaction is something like a lock and key arrangement. So the lock is, or the key is devised for the particular lock. So what is mean by your antibody level or anti-spike antibody means you have got the key in your hand. So if the lock is available, you can just open the lock. So lock is the virus. So if the virus is there, your antibodies can neutralize the virus. That is the meaning of the presence of anti-spike antibody in your blood. So theoretically, if you look at maybe in the first, just look at the things, you may be thinking that if the virus is coming to attack you, you have got the anti-spike antibody in your blood because of vaccination, then you are going to neutralize the virus. But this may not happen in 100% of cases, because vaccines are made out of viruses which were circulating in February and March of 2020. Now the virus is that of 2021, maybe December or November. So the virus is more evolved than the antibody in your blood. Your lock is actually more evolved than the key in your hand. So you may not be able to open all locks by the old key that is there in your blood. That is the problem that you are facing. So you can get an infection, okay? But the partial immunity that I have already mentioned is going to protect you from severe kind of diseases and death. That is why we are speaking about the breakthrough infections. That means even though your immune status is good, you have got high titers of antibody, again, you can have an infection because of Delta, because the immunity for the antibody is not against Delta. Okay, it is against the Wuhan strain of virus. So you can be infected with Delta, but the chance of severity and death will be much low. That is the advantage of vaccine. But suppose you have got an infection already. If that infection is because of Delta itself, definitely you may be having a sterilizing kind of immunity. That means the Delta is not able to infect you because you have got the key, which is as new as the lock. So you may not get the infection at all. That is the advantage of a natural infection. If you have got a natural infection, or once there is a COVID affected, especially for the last 6 months, you may be having an additional immunity. But in the presence of Omicron and all, you do not know how it is going to give you some additional protection. Again, if that is the same thing I was actually trying to discuss. If Omicron is going to sweep, everybody are again at risk of an infection, but definitely not at risk of death and severity as we have already. That is one aspect. And I don't mean that Omicron is going to sweep, but there is even among the all types of viruses other than Delta that we have, Omicron is the potential danger that in the horizon now.
Does anyone have any questions? Since nobody else is having any questions, shall we end the discussion session here? Thank you, sir, for joining us here and giving your valuable time when you are actually having a busy schedule. The session was really informative, and you gave a lot of things that we really didn't know. Thank you, sir, once again. By today, our 4 sessions of our webinar series are successfully completed. Without our eminent speakers, this wouldn't have accomplished. We thank Dr. Manasi Ravindranath, Dr. Devraj, Dr. Biju George, and Dr. Anish, sir. I also thank all the participants who have joined in these 4 sessions. Thank you all. We would like to hear your feedback, so kindly fill the feedback forms that is sent in the comment box. We will be uploading the sessions in our YouTube channel, and link will be shared via mail. Also, the certificates will be sent within 2 weeks through corresponding email. We wish you all an enjoyable weekend. Thank you. Thank you all.